Good afternoon, everyone, and thank you for joining us. We are part of the Early Career Professionals Working Group of the Thoracic Oncology Assembly, and Adam and I are hoping to put together this webinar on, hey, can you treat this with radiotherapy, radiation therapy for a pulmonologist? And we have with us Dr. Abraham Wu, who's joining us. Just to briefly sort of introduce myself, my name is Tejaswi Nadig. I am one of the interventional pulmonary fellows at the Memorial Sloan Kettering Cancer Center. And we have Adam Fox, who is an assistant professor at the Medical University of South Carolina, who will be co-moderating this webinar with me. And joining us as a guest speaker, we have Dr. Abraham Wu, who is an associate attending in radiation oncology at the Memorial Sloan Kettering Cancer Center. Thank you, Dr. Wu, for joining us and accepting the invitation to sort of educate us pulmonologists on what radiation and radiation therapy is.
My pleasure.
So sort of, we wanted to start off traditionally as with multiple other presentations on with a case. And this is an 81-year-old female who had a prior history of adenocarcinoma post a right upper lobe wedge resection, over 12 years ago, who presented with a newly diagnosed right lower lobe adenocarcinoma stage 1A, and based on size, I guess, stage 1A3. Now, with this being in the picture, and let's say surgery not being an option for her, Dr. Wu, the question for you would be, how would you think you would sort of approach this case, given that surgery is not an option?
Yeah, so this is certainly a very common and important clinical scenario for us as radiation oncologists. And for a stage 1 non-small cell lung cancer, I would say there's now generally a consensus that the optimal non-surgical treatment is going to be SBRT. There certainly are other options, but the one that has by now the best track record and most proven results is going to be SBRT. So yeah, if it's been clearly documented that the patient is not a surgical candidate, or as is sometimes the case, that the patient very clearly does not want an operation, then I definitely recommend SBRT, which is, of course, totally non-invasive and also has quite high rates of success. So generally, that's how I would frame it for the patient. Of course, it's a more nuanced discussion if surgery is still on the table in some fashion.
Okay. And so just for us and going through training and now even in IP fellowship, it's not like we really get exposed to sort of the basics of what SBRT is or what radiation therapy is for any for us pulmonologists, sort of just maybe dumb it down to say, okay, this is what we're going to do to this cancer.
Yeah, so the radiation therapy is of course the use of ionizing radiation to treat cancer. And of course, this is kind of on a spectrum with diagnostic radiology, where of course X-rays are used to diagnose cancer. And in many ways, the most common form of radiation, which is external beam radiation delivered from a linear accelerator, is kind of like a CAT scanner that's been sort of souped up, to deliver a much higher, energy beam of X-rays or photons. What radiation does, what ionizing radiation does, essentially is it kills cancer cells through DNA damage. So the ionizing radiation inflicts various forms of DNA damage, and that then leads to cell death through a variety of mechanisms, apoptosis, mitotic cell death. And that's essentially what's happening. And what's important to note and what's key to the success of radiation is that in general, cancer cells are more susceptible to cell death, as a result of ionizing radiation, because obviously the radiation passes through the body, so it also affects normal cells, but there's a differential effect on the cancer cells. And some of this is also related to the fact that normal tissue cells are generally better able to repair radiation damage compared to cancer cells. So you're also trying to exploit that. And incidentally, this is the fundamental reason why radiation therapy traditionally has been highly fractionated. In other words, delivered in multiple small doses as opposed to all in one big dose.
Okay, makes sense. Thank you. Now, what are sort of the expected outcomes of SBRT? We have some data on how good surgery is, but can this be an absolute alternative to surgery?
Yeah, it's a really important question, and there's a lot of nuance and of course some remaining debate on whether SBRT can be considered equivalent to surgery. We can definitely say that the outcomes from SBRT are generally quite good, and the essentially the reason SBRT has worked out so well is that we're effectively giving much higher radiation doses compared to what can be achieved with conventional, traditional radiation. So, say 20 or 30 years ago, before we had the technology to deliver SBRT, we could only safely deliver moderate doses of radiation, and those would usually achieve local control. So you could say, the chance that that would sterilize the tumor completely might only be on the order of about 50%. But with SBRT, you're often effectively giving 50 or 100% higher radiation dose to the tumor compared to traditional radiation. And, as you might expect, this is much more likely to achieve complete tumor cell kill. And what we have now seen is that with SBRT, the chances of durable local control are on the order of 80 to 90%. And so they're really quite high. And once you're up in that range, even though we cannot say that this is exactly the same as surgery, which remains the gold standard in terms of local control, I think most people would agree that once you get to about 90% probability, it's effectively very, very high, and it makes it a reasonable choice, even if one could possibly still get surgery.
Okay, makes sense. And I know we have this slide up that, and talking to you previously prior to this webinar too, you're talking about how this study back in 2010 that sort of put SBRT on the map for lung cancer, and I think that one on the left had a 3-year follow-up, and then subsequently they had a 5-year follow-up. I wanted to see if you wanted to comment on sort of success.
Definitely, and I think this is important to put into context, especially because what you're seeing there in terms of the survival curves is overall survival, which is of course different than local control. And this study it's the RTOG 0236 study, which I know doesn't not going to mean anything to this audience, but that's the at least formerly was the main cooperative group for multicenter trials in radiation therapy, and this was a multicenter phase 2 trial of SBRT for peripheral stage 1 inoperable lung cancers. And this study was very groundbreaking because it was the first published multicenter prospective study of SBRT for this population. This was published in JAMA, so of course in a high-profile journal, and it really validated that SBRT could achieve very high rates of local control. And in fact, in this initial report, which they reported it was actually 97 or 98% local control, because only one out of the initial, I think, 40 or so patients had a local failure.
Yeah.
Subsequently with longer follow-up, that's gone down a little bit, but we're still in the kind of 90% range. So that really put it on the map. But what I do want to say about this particular graph, because obviously if you're looking at the figure, this is clearly not 90% of anything, right? This is of course much lower. You're looking at lower than 50% overall survival. And this obviously reflects two things. This reflects, first of all, that if you're starting with a medically inoperable patient population, then of course their 5-year survival independent of cancer is not going to be great. And then of course also reflects the fact that the main cause of mortality, even in early stage lung cancer, is not local failure but distant metastasis. Right. So that's always a distinction to be made between survival and local control.
Perfect. No, makes sense. Yeah. And, when I was looking through this too, that's the sense that I got. I was like, initially I was like, oh, what does this mean? I thought SBRT was great, but how are so many people dying? And then, I guess the starting point of patients, they're not the same category as what, the ones that do get surgery and do well are. So it makes total sense. Now, with just this, right, again, as I said, we were talking about SBRT, but then there is also this entire alphabet soup of, EBRT, IMRT, proton therapy, brachytherapy. There are so many of these modalities that we associate with radiation oncology. If you could explain to us sort of the brief, differences between them, I think it would help the audience.
Yeah, definitely. And it is challenging because these categories are not mutually exclusive. And there's the most basic distinction would be between, you could say, EBRT, which is external beam radiation therapy, versus brachytherapy. So this is just basically external beam radiation versus internal radiation. The brachytherapy is just implanting a radioactive seed inside somebody, and that generally is not relevant for lung cancer. And the vast majority of cancer patients who get radiation treatment get external beam radiation, although brachytherapy is very important for particular cancers, particularly prostate cancer, which is, of course, not our topic today. But for lung cancer, it's predominantly external beam radiation. And then external beam radiation, the vast majority of EBRT is photon radiation, or also known as X-ray radiation. That's where the categories of SBRT, IMRT, these all refer to different techniques of delivering photon radiation using a standard linear accelerator, which is the machine that we use. And the differences that you get, the alphabet soup, this is all related to how the radiation beam is shaped, the techniques that you use to calculate the shape of the beam, and how it's computed, essentially how a radiation plan is generated and delivered. So in addition to SBRT and IMRT, you've also got IGRT, so many different acronyms. For our purposes, SBRT, this stands for stereotactic body radiation therapy. And further confusing things is that it also commonly is referred to as SABR, or stereotactic ablative body radiation, and these are exactly synonymous. And essentially, the key characteristic of SBRT is really two things. One is that you are using special techniques to be very precise, typically image guidance, meaning that when you're giving the radiation treatment, it's image guided, kind of like a CT guided biopsy would be. It's analogous to that's how you are being very precise with the radiation beam. And it's because of that precision that you're then able to give very high doses of radiation to the tumor safely, whereas if you weren't using those guidance techniques, then you'd have to treat a larger area, which you then could not deliver as high doses, safely. So that's really what SBRT is. And then, the other acronyms that you'll hear, IMRT, et cetera, pretty much very technically limited to radiation oncologists, exactly how those work. The only other major distinction that we would need to make really is proton therapy, right? So proton therapy is, it's still a form of external beam radiation therapy. It's still ionizing radiation, but it is distinct in the sense that it now involves a different machine entirely that delivers proton particles as opposed to X-rays. And the main characteristic of protons is that they're able to deliver less, the radiation dose does not spread out as much to the rest of the surrounding tissue around the tumor. So you can reduce the amount of sort of low dose radiation spread, and that in some cases can reduce the toxicity and allow us to treat certain areas that we otherwise would not be able to safely treat. For example, if you're going back and you're treating an area of the body a second or a third time with radiation, protons often are useful. Protons are not usually used for SBRT. Usually we still use standard linear accelerators for SBRT.
Okay, got it. Thank you. I think that helps us sort of figure out, when we're asking for radiation therapy, what we're actually asking for. And also yeah, sorry.
Just to set the audience, we briefly touched on this, but it's such an important topic for any of those who aren't read in the area in terms of SBRT or surgery for a stage 1 lung cancer. Dr. Wu, you kind of mentioned that this is really for those that are deemed inoperable, as is mentioned in the title of this report here. But the problem we have as a community is that the populations who typically get surgery or typically get SBRT are just wildly different. Those who are medically inoperable for a stage 1 tumor often have competing comorbidities that might limit their survival anyway, whereas many, especially in clinical trials, who get surgery for stage 1 maybe even be healthier than the average population of patients with lung cancer because of how some of these trials are selected with comorbidities and performance status. So just wanted to set that aside for the last question, just for the audience who may not be aware.
And also in terms of the audience just having any questions, we will field all the questions in the end. But if you have any, you can also just put it in the chat box, and Adam and I will be monitoring that. And now just moving on from, so we sort of know SBRT is good for, peripheral stage lung cancer. Now, the question that I'm sure Adam's patients ask him, and I've had some in our IP clinic, ask about, what do I experience when you say, hey, yes, I'm going to refer you to radiation therapy. What does the patient sort of have to expect? He comes, sees you, or he or she comes and sees you in clinic, but then what happens after?
Yeah, and I would say for SBRT in particular, the one-word answer, which I'm exaggerating a little bit, but the one-word answer would be nothing. In the sense that this is external beam radiation therapy, and so there's literally no sensation while you're getting it. I usually describe it to patients as similar to getting a CAT scan, a little longer than a typical CAT scan. Usually 15 to 20 minutes, but otherwise similar in the sense that you obviously do not see or feel the X-rays as they are passing through the body. And for SBRT, though, it is particularly the case that not only is the treatment itself totally non-invasive and free of any particular sensation, but that the side effect profile is also generally very benign. We'll, of course, talk more about side effects. Certainly, there are risks, just like with anything. But the majority of patients with SBRT experience minimal side effects. The most common one is fatigue, which usually sets in after the 3 to 5 days on average of radiation's done, and then they'll just feel a little bit more sluggish for maybe another week or two. And I would say 90% of the time, that's all patients ever experience. And so it's quite common for patients to joke that, did I turn the machine on? How do I know it's working? Things along those lines, just because SBRT typically involves such a small target. And, that's in contrast to what we'll discuss later, which is, of course, for more advanced presentation of the lung cancer, where you're treating larger areas of the body, larger fields, and often getting chemotherapy. Of course, that's a very different scenario where side effects are much more pronounced. But for SBRT, the most common reaction is that they feel like nothing happened and they were a little tired for a couple of weeks, and that was it. And that's quite gratifying.
When especially when the alternative, or I guess, when everybody knows things about surgery, how they have to be in the hospital, this seems to be more like, oh, I'm going to come in, get some radiation, and then get out, which seems more palatable. Now, with that itself, how do we sort of choose, how long they're going to get SBRT? How many days do they need it? Is it, just a certain number of fractions for a certain number of days? Is it prolonged, especially, again, focus more on, earlier stage cancers?
Yeah, so SBRT, for the most part, is almost exclusively for early stage cancer, meaning node negative, right? So you're talking about the T1, T2, and 0 type situations. And before I describe the basic principles of the number of treatments, I should point out that the radiation process, in terms of what patients should expect, is that they first need to get something called a simulation, which is essentially a special CAT scan in which we map out the part of the body that we're going to treat and create essentially a model, a CT model of the patient's tumor anatomy, and then do our radiation design on that CT image set. And during this simulation, patients get tattoos, which I'm sure you know that patients get tattoos as part of this, and commonly patients will also have certain molds and other immobilization devices fabricated during the simulation so that they're properly immobilized for the treatment. Now, as far as the number of treatments and fractions, so SBRT for lung cancer typically is between 3 and 5 fractions of radiation. That's by far the most common. That's where the foundational clinical trials essentially have been 3, 4, or 5 treatments. And there are some variations, but we typically deliver these on consecutive weekdays. So we generally don't treat on weekends, but Monday through Friday, or however consecutive business days may fall. And in terms of how many treatments, generally speaking, the more complicated or higher risk the situation, and things that are higher risk would be tumors being closer to the mediastinum or central airways. That's the main reason. But sometimes tumors being abutting the chest wall, or tumors being very large. In general, the more complicated the scenario, the more fractions we give. And this is a little bit counterintuitive, because most patients would naturally assume that more means more dose. But in fact, we're actually becoming less aggressive rather than more aggressive, because what we're doing is we're essentially spreading out the radiation dose over more sessions, with the idea that that's a gentler kind of way to do it. And then for the least complicated, which would be a small peripheral tumor, those are the ones that we typically give 3 fractions of radiation. And on occasion, there's actually pretty good evidence base for even doing that in a single fraction. So you actually can give just kind of one very large dose of radiation, which is not the norm, but is a useful schedule to be able to offer to a patient who might live far away, for example, from the radiation facility.
Oh, makes sense. Okay. Go to the next slide. So with that, I know you sort of already touched upon this, but how do you sort of, model your targets? And, is there ever a point you're like, what, maybe let me include some of the nodes or so?
Yeah. Well, so this is really a question of staging, and I know this audience, I'm sure, is of course very well versed in that. So as I mentioned, SBRT is really for stage 1, or at least for node negative patients. So that's really a matter of clinical judgment and clinical workup about whether you've established that the patient is N0. And because generally speaking, SBRT never includes nodal stations. If you thought that you had to, then by definition, then that would presumably be a more advanced stage patient, and then SBRT would generally not be advisable for those patients. Giving very high doses of radiation in just a few fractions generally is not safe for structures in the mediastinum. So SBRT pretty much never includes the nodes. Of course, how we establish the nodal status is a nuanced issue. Of course, these patients are all getting PET scans, and we're generally assuming that there's nothing on CT or on PET that would raise suspicion that there's lymph nodes. But it is often advisable to consider invasive mediastinal staging. And of course, that's where your discipline often comes into play. So doing an EBUS would be the most common scenario. And in practice, of course, this is a very individualized and practice dependent situation. It depends on the patterns of practice in a given facility, as well as the situation of the patient. And of course, patients who are getting SBRT because they're medically inoperable, often are not looking for a lot of additional tests and invasive procedures. So I would say that in practice, the majority of the time, we are relying on the PET scan, and if it's negative for mediastinal nodal involvement, then we generally will assume that that's the case. But I always try to have a discussion with the referring surgeon or pulmonologist about whether they would consider an EBUS for a patient who has who's on track to get SBRT.
Okay, thank you.
Thank you, Tejas. I'll take over for a few questions here. Dr. Wu, I'm afraid you're still on the hook for more talking. We wanted to ask you, what were some of the common complications, and how does this relate to surrounding structures and how that might change your treatment?
Yeah, so for SBRT, as I mentioned, it's generally rare to have significant complications. The two most common complications in the longer term, I already mentioned, of course, short-term fatigue, and occasionally you'll get things like cough, or rarely some nausea, some radiation dermatitis. These are occasional, transient, mild short-term side effects. But what's really clinically meaningful is what might be the complications later on, months down the line. And the most important one really is pneumonitis. And this, of course, is of great interest to your specialty as well. The incidence of radiation pneumonitis after SBRT is typically reported in the 5 to 10% range. So it's a minority, but obviously not insignificant. This is less than for traditional radiation. With large radiation fields, pneumonitis rates are typically reported around 20%. And so you could say it's at least half of that with SBRT. But that's really the major one that we counsel patients about and have to be on the lookout for. And radiation pneumonitis, of course, typically manifests anywhere from about a month after radiation to sometimes 6 months or more. And that risk is related to the volume of lung that's being treated. So the larger the target, or really the more lung that's exposed, which depends not only on the size of the target, but also obviously on the number of targets in the lungs, and then also on the location. So tumors that are more towards the base of the lung, the radiation has to go through more lung, compared to something that's at the apex of the lung. So this is a big part of our radiation planning process, is that with our simulation and treatment planning process, we calculate and model and try to optimize the volume of normal lung tissue that's exposed to radiation and try to minimize that as much as possible. So that's the main issue. The other common complication after SBRT is, we just call it chest wall pain, which is exactly what it sounds like, which is a phenomenon where patients develop what's most likely a neuropathic type pain in their ribs or soft tissues, again, also several months after the radiation. And we think that this is probably related to small nerve injury. Sometimes it can be related to rib fracture, because SBRT can also decrease bone density and make it more likely that you'd have a traumatic rib injury leading to fracture and pain. And this, of course, is very much a function of where the tumor is located. And so a tumor that is plastered up against the rib cage, of course, is going to be at a much higher risk for developing radiation chest wall pain compared to somebody with a tumor that is more centrally located in the lung. So those are really the big two. And then, you mentioned esophagus. There are other possible complications that are very specific to the site where the tumor is located. So esophagus is obviously a major concern if the tumor is close to or abutting the esophagus. And likewise, you could say that about any kind of mediastinal structure, the heart, the major airways. Tumors that are in the apex of the lung can be close to the brachial plexus. And then tumors that are close to the diaphragm, then you can start potentially having to worry about stomach or bowel. So we can certainly discuss any of those in more detail, but that's kind of an overview of some of the concerns.
Sure. I believe this is the first patient's image who had that upper lobe nodule. I think that you shared this image with us. The nodule was somewhere in that region. And this was after treatment. Was this delayed, you said, by about 6 months or a year, these images?
Yes, yes. So this would be very typical for a patient at about 6 months after. And with SBRT, I always like to say, delivering the treatment is very uncomplicated, but judging the follow-up and interpreting the scans afterwards is actually where things start to get complicated. And that's because, as you see here, it is expected and very characteristic after SBRT to see a lot of lung changes and fibrosis and consolidation. And that can make assessing tumor response challenging. And we would see this, and the patient may very well be asymptomatic. So of course, seeing a scan like this does not necessarily mean that anything symptomatic is happening or that anything has gone wrong. But obviously, it can make it challenging to interpret the response to treatment. And in some cases, the patient may be having symptoms of shortness of breath, and then you have to try and rule out radiation pneumonitis versus other common causes of dyspnea in this patient population.
Yeah, I think these images are extremely common at our local tumor board, because our radiation oncologists and other physicians see images like this and say, "Oh man, I wonder if this is somehow their cancer." And we all have that debate over a PET scan, it seems like, which of course these radiation changes can have PET activity within them, which might further complicate the picture in some ways. Not all new data is meaningful or helpful even. But yeah, I think this is something that we see very common on our tumor board. And I think, every patient, it's pull up all the images with our radiologist team and try to figure out how likely recurrence or something else is. I totally agree.
Yeah, and this is a very common scenario where patients who've had radiation, if they present to a separate facility, let's say they walk into an urgent care center and then they get an X-ray or a CAT scan, then naturally they get extremely alarmed because the report on the X-ray or CAT scan will say something like, opacification of the lung, cannot rule out malignancy, and you can imagine the anxious phone calls that this generates. So obviously, the clinical context and then having the ability to compare to previous CAT scans is crucial. And you mentioned PET scans. I think that's also a important point to make, which is that in the immediate aftermath of SBRT or of radiation in general, doing PET scans often sheds more heat than light on the situation because radiation causes inflammation, which can persist for months, afterwards in the radiated tissues. So if you reflexively get a PET scan because your X-ray or your CAT scan looks a little funny, the PET scan probably is only going to make things more concerning, even though the FDG avidity that you see may very well just be post-radiation inflammation. So we try to avoid getting PET scans unless we have a very specific question that we're trying to ask. Usually within the first, even up to, well, I would say 6 months to a year after radiation. We generally will follow these patients with a standard CAT scans only.
And would you also say that the shorter interval, even judging a 3-month scan after SBRT, can be these kind of early changes you can see can often be misleading? Is there really growth there, or is this just inflammation surrounding the target?
Yeah, so with SBRT, getting serial imaging is really key, and our usual cadence is every 3 months, and so we don't get them right away. Because we wouldn't expect to see any meaningful changes that we could judge if it's done, within a few weeks after radiation. So our first one is at 3 months. And 3 months is helpful because that's often before a lot of the radiation fibrosis and consolidation sets in. So most commonly, it's actually between the 3 and 6 month mark. So I like to get the 3 month scan because usually that's before everything gets completely obscured by radiation change. And then when the 6-month scan rolls around, very commonly you'll start to see a lot of kind of what you just saw on that scan there. But you just need to follow it over time. You know, if you just have a scan like this, just as one snapshot in isolation, it really is virtually impossible to say anything definitive about, is there a cancer growing back in there or not? You know, but if you can follow that over time, then you can have more confidence to be able to distinguish between post-radiation change versus a recurrence.
Absolutely. I think the next slide gives you just a slight reprieve. These were just kind of show and tell pictures collected. This first one, you can see there's an esophageal stent here, and about right here probably is where tracheoesophageal fistula once resided, probably the reason for the stent. And this was suspected to be a complication of radiotherapy to a very central tumor. And then similarly on the right-hand side here, on the top T tumor here, there was a tumor that was basically in the subcarinal location that received SBRT. This incidentally was not a lung cancer, but was in the lung. And you can watch the arrow of the right BI here over the course of almost an entire year slowly get smaller and smaller, and she eventually presented with kind of obstructive type symptoms and required a balloon dilation with at least clinical response. I think it's been about 2 months now. She had a nice clinical response to that therapy. But these were just kind of show and tell pictures. If there's anything you'd like to add, though, for sure, feel free.
Yeah, I think that these are, of course, a cautionary tale that, you know, even though the vast majority of SBRT patients do not have any significant complications, there's always the possibility of something more significant. I think the important thing for these, to put these into context, is, as I mentioned before, that this is entirely correlated to the location of the tumor. So something like a esophageal or fistula from SBRT would be virtually impossible unless the tumor itself was basically within about 1 centimeter of the esophagus, and especially if it were abutting the esophagus. You know, there's zero chance of this happening if you're treating a tumor that's in the periphery of the lung, because obviously there'd be virtually no radiation dose that's given to that area. The airway stenosis is sort of a similar thing as well, so that's just important to keep in mind. But in general, it is the centrally located tumors where we become much more judicious about the SBRT, whether to give it in the first place. Although, you know, nowadays we usually don't hold back, mainly because if you think about what were the other options, right? What other local therapy options are available for something very centrally located? It's usually an even bigger problem, you know, from the standpoint of surgery or ablation. So we will usually end up recommending radiation anyway, just with the understanding that now the risks exist for certain rare but potentially serious complications, particularly like the esophageal fistula. The airway stenosis issue, that is not super well characterized in terms of how often that happens and what the predictors are for that. But certainly that's one where, and a situation where our disciplines may interface, right? These are patients that you end up seeing and may be asked to try and you know, address some of these consequences of radiation if they're having obstruction that's not malignant in nature, but maybe related to fibrosis from the radiation.
Absolutely. So I think one of our last questions was, how does size, you know, we talked about location, but how does size play in to SBRT? And I think this might just be a picture of a rather large tumor that I think Tejas found for us. Yep. Oops, sorry, I didn't mean to go back. How does size play into SBRT?
Yeah, so radiation of the various local modalities, you know, surgery and ablation, you know, size probably is the least limiting for us as radiation oncologists. So size per se is not usually the limiting factor. It is more the adjacency to other critical structures that becomes the issue. So there's no inherent upper limit to how large of a tumor we can treat. That said, the majority of the SBRT experience is really for tumors less than 5 centimeters. So that's really the main thing. It's not so much size; it's whether it is close to other critical structures, but otherwise, we can treat it.
Yeah, I find it hard to believe that a 8 centimeter tumor isn't close to something.
Right,
It
exactly. Yeah.
it's getting near something that could get hurt, I suppose. Um, and then another common discussion at our tumor boards is how does interstitial lung disease, which of course is a loaded question because that composes of so many different diseases, but how does ILD work into the ability for SBRT? Our kind of case scenario here, that arrow points to a nodule that had grown over time and was biopsy proven to be adenocarcinoma. That was just kind of our case example to anchor this discussion.
This this is a very important issue for us as radiation oncologists. There's only a handful of conditions that really give us pause, and to be frank, this is one of them, because it is generally held that radiating patients' lungs who have ILD is a high risk scenario, and really one of the rare situations where we actually start talking about fatal complications from radiation. So it's certainly not something we do lightly. That said, kind of like I was saying before, we have to consider what are the alternatives, for such a patient, especially if you're dealing with a life-threatening malignancy. So our approach with these patients has been, of course, to have a very careful discussion about the risks and the benefits. And what becomes really relevant is the patient's goals, but also their life expectancy. And the usual rule of thumb that I've been using, which is basically to ask, do we expect this patient to have independent of their cancer, do we think that their life expectancy is going to be more than a year? Because that's roughly the horizon where we think that an untreated stage 1 lung cancer would become life-threatening. So, if you think that their comorbidities are going to, end their life within a year, then you may want to consider not doing any treatment at all. But if it's gonna be longer than that, then it becomes a more reasonable consideration. So when it comes to this scenario, there's a couple things. Sometimes we will refer these patients for proton therapy because, like I said, with protons, you can limit the amount of low dose radiation spread to the rest of the lungs. That might be more favorable. But otherwise, we simply proceed, as carefully as possible, and just making sure that, the patient's goals are aligned, with the treatment plan. And then, of course, these are the ones where I call you up, and just make sure that you're also on the same page and prepared for, the possibility that the patient somehow decompensates.
And I think we had an article for those who wanted to read more. This was a recent article this year on a clinical trial for SBRT in early stage non-small cell lung cancer for patients with ILD. The ILD didn't appear to be significantly advanced from an FEV1 and FVC standpoint. I think their kind of median DLCO was around the 50 percentile or so. But there is some emerging evidence in this field, this being a non-randomized trial, but certainly a good read, and hopefully we have more to come in terms of higher and lower risk patients. We also briefly spoke about a few indicators, a particularly troublesome group of patients, it turns out, for lung cancer in general are people with severe autoimmune disease. We have trouble, almost anyone that's above stage 1 might be eligible for immune therapy. It's certainly, if you don't have a targeted mutation or even have some of the target mutations, immune therapy might be beneficial in your care. But it can be limited in severe autoimmune conditions. There's some particular conditions that may warrant pause and radiation as well related to that.
Yeah. So In addition to ILD, patients with severe autoimmune disorders, particularly scleroderma and to some extent lupus, those patients do also appear to be at a heightened risk of severe radiation complications. So we proceed with great caution in those patients. And again, we would use every sort of trick up our sleeves to try to, optimize the radiation technique, protons or other radiation techniques. But again, having in mind that if the patient has no treatment alternative, then it may often still be the right thing to do to go ahead and treat with the understanding that there's a higher risk involved. This particular study is a very fresh study and an important study because it's, I believe, the first completed prospective trial of SBRT in patients with ILD, and it was considered a success in the sense that it met its endpoints. But to give you a sense of what we were expecting, they were going to deem it a success if I think it was like less than 15% grade 5, i.e. fatal toxicity. So that, of course, in a general population, it would be horrifying, right, to have a 15% rate of fatality with SBRT. But in this study, it turned out to be something like 7 or 8%, and that met the endpoint. Obviously, that's still very unfortunate for those patients, but the fact that that was considered better, than their target, gives you a sense of the magnitude of the risk that these patients face.
Absolutely. A similar related question to some of these topics we've had. How do you approach the patients who say, "Look, I don't want a lung cancer biopsy. All indicators are perhaps for early stage, no nodal disease." How do you practice, or perhaps maybe an interventional radiologist has, or pulmonologist both have declined the case due to risks? How do you approach those?
Yeah, so obviously, we encourage patients to get tissue diagnosis whenever possible, and particularly if it's they don't have a prior diagnosis of cancer. But yes, it is not uncommon, for a patient to be referred after the interventional radiologist has deemed them to be very high risk for biopsy. So then, usually we would look for other evidence that this is malignant, and so of course FDG avidity on the PET scan and serial growth, on scans in terms of size, and if we have that kind of evidence, then I have a discussion with the patient, and I say, this is most likely malignant. There's always a small chance that it's not, in which case, the treatment obviously would be not helpful to you, but most likely it is malignant. And most of the time they'll agree to go ahead with that, and I just document that. But I do think it is important still to make that sort of an exception, because of course there's multiple reasons that having a tissue diagnosis is helpful, to guide future treatment, of course. And obviously, just because the lung nodule is malignant, there can be significant implications if that's non-small cell versus small cell versus metastasis.
Yeah, I think our practice is similar at my home institution here at MUSC. We definitely prefer a biopsy when possible, but sometimes that's just not practical. The other thing that comes to mind are those who maybe underwent a biopsy and maybe had a complication, but the results are the pesky atypical cells, just not enough to tell. That can also be a not so fun scenario, having already undergone a biopsy with that kind of result. What is your practice towards EBUS prior to SBRT for tumors?
Yeah, so these are, of course, all nuanced topics, and for the sake of time, I'll keep it short and sweet. But essentially, we don't mandate it. We really tailor it according to, obviously, the patient, condition and tolerance for further invasive testing. But generally speaking, a small peripheral tumor, of course, assuming PET scan everything is reassuring, we're less inclined to do it. Whereas a larger tumor that's more centrally located, so something, more than 3 centimeters and in the central lung zone, we would be more concerned and would be more likely to press that. So I always do try to have a discussion with the referring surgeon or pulmonologist about whether they would consider doing an EBUS before I do SBRT. But I would say more often than not, we end up not doing it.
And thanks for calling attention to time there. We will probably skip a little bit here. I think we've got two kind of final topics here of just a brief overview. Can you contrast everything we've spoken about so far about SBRT? What are some of the big contrasting points compared to the radiotherapy that's delivered in advanced disease, like in stage 3 non-operable disease?
Yeah, so basically, once you are dealing with node-positive disease, SBRT is essentially off the table, and then you are in the realm of conventional or more traditional radiation. And so then you're talking about sometimes 6 weeks of daily radiation, 30 sessions of radiation. And this is optimally given with concurrent chemotherapy. So a unresectable stage 3, non-small cell lung cancer, the standard would be 30 fractions of concurrent chemoradiation. And, in a sense, it's the same treatment from a radiation standpoint. It's the same machine. It's just that the radiation field is now much larger. The amount of the dose of radiation each day is much lower. But because of the larger target, and especially if you've got chemotherapy going at the same time, the acute toxicity is significantly greater. And the main issue for these patients is esophagitis. So it's quite common for these patients to get really symptomatic esophagitis and to run into issues with pain control and nutrition, during the treatment. So that's really the major thing. I already alluded to, there's certainly a risk of pneumonitis, which is higher than with SBRT. So this kind of treatment, the vast majority of patients can get through it, but it certainly is much more significant in terms of side effect profile than SBRT.
Absolutely. I think for sake of time really got away from us there. We could this is another recent paper for those in the audience who might want to read about EBUS to guide radiotherapy, hot off the presses as well. And I think we should probably go ahead and open up. I'm sure we have a few minutes for questions. But thank you again to Dr. Wu for joining us today. And please put your questions in the chat and we'll try to field them for you. Thanks again, everyone, for joining. And thanks again to the ATS Thoracic Oncology Assembly for helping us host this webinar.
Yeah, happy to take questions if anybody wants to type one in, or I don't know if you can unmute yourself even.
Yeah, I think we're in a small enough forum here that certainly if you guys wanted to unmute and say hi, that'd be totally fine.
Hopefully it was relatively clear.
Yeah, there was no questions, so you must have really it explained all of thoracic oncology in this 1 hour. Everyone's done. Tejas, was that you?
No. But no, I think it was really helpful for me, given that I'm always like, oh yeah, we can send this to radiation, but then not knowing anything about it. No, my hope, I was like, oh yeah, sure, we can get you to a radiation oncologist, and that would be the end of my, I guess, knowledge. But no, I think this was very helpful to just sort of know what the patient one faces and what, we can also sort of counsel them. Helps me at least counsel them better now.
And I think, Tejas and I are always thinking about what treatments, and probably many on the call, what treatments are patients eligible for, what is going to be best served by them. I think until we get to see patients and really learn a little bit about the field, I keep joking that I'm still becoming a pathologist, oncologist, surgeon, and radiation oncologist. I don't do any of the work, but I still have to know a little bit of what's done on a daily basis. I think that until you start to learn a little bit of the ins and outs, you can't really appropriately get people to those next steps effectively. We see people in these really trying times as pulmonologists in between a diagnosis to what are my options, and it's like, well, when I first meet you, who knows? We need to know a lot more before I can tell you what your prognosis is, much less what the next 6 months are going to look like for you. So really, this was I think a great session, and I really appreciate everyone here.
Sorry, I have a question. It's Rubin Singh from Chicago. Can you comment about this mobile, essentially radiation therapy on a truck? Again, we are talking about rural installations that don't have access to. I'm practicing at the VA. 90% of the veterans essentially are in the rural areas. Schlepping all the way can come to them, so to speak. Maybe not even upstate New York. I don't know. Just a question. So I don't know if there is information. I think I saw one publication. Go ahead.
Okay, yeah, if I understood correctly, I think you're asking about the possibility of doing mobile delivery of radiation therapy. To my knowledge, I don't believe that there is any solution right now to deliver, just have a mobile radiotherapy clinic. It's possible that maybe what you're referring to is some sort of diagnostic radiology facility, which I believe.
No, there is one. There is one company. Again, I don't have the details now. There is at least one that does that. And I think, as I said, the challenge is the rural patients that don't show up to their appointments. Essentially for radiation. That's really the challenge that we have. So of course, in urban area, no problem, but in a rural area, people are stuck, and they shoot on the streets or on the highway, so they don't even want to bother for that. So just a question whether it's future direction. I'm not saying that we have an answer now, but just to think about it. Thank you.
It is, yes, for sure. I mean, yeah, to be perfectly honest, that's news to me. If there's actually, some sort of facility, some sort of operation that's literally delivering mobile radiotherapy, because I think the challenges would, unless you're doing a very, very crude type of radiation, the challenges would be immense in trying to do that on a mobile thing. As I mentioned before, I think one of these solutions that we try to come up with is actually SBRT in a way has made it more accessible because the treatment is so much shorter. Right, 3 days of radiation is way better than 6 weeks, or even a single session of radiation we can sometimes do.
Absolutely,
that makes it more practical.
I think I heard the VA.
The input from the trenches, I guess. That's what I'm trying to say.
Yeah.
Thank you.
I'll never be surprised about what the VA wants to put on a truck. That's for sure.
Right.
They are the leaders of mobile healthcare for sure. Any other final questions?
I would try this reference because I was dealing with that, and essentially that's how we came about. I forgot what's the name, but definitely there's one. But definitely, look, and then maybe for if you're interested. Thank you about that.
Thank you.
Fantastic. All right, everybody. I think we've made it to past 5 here. Thanks again to everyone. Have a great evening.
Thank you all for joining us.
Good night, everybody.